live streaming.
Okay, good evening and welcome to today's discussion, our usual live PLAB-1 discussion class. Okay, so today we'll be talking about dementia. Okay, and dementia is an example of a neurocognitive disorder. All right, so we're zooming in on the dementia, the types of dementia, the common types of dementia, and then the symptoms that you commonly get and how to differentiate one from the other. Right, so by way of introduction, dementia could be an acute onset, sudden onset, or chronic loss of cognitive abilities. All right. So, and when you talk about cognitive abilities, you're talking about memory, personality, all these things are cognition. When you are talking about mini mental states, attention, okay, even orientation, all these are cognitive abilities. Ability to recognize a face and know that yes, you have seen this face before is a cognitive ability. Memory, like we mentioned, short-term and long-term memory. Okay, so we want to take a look at other cognitive abilities. So they are defined as brain-based skills we need to carry out any task, from the simplest to the most complex. All right. They have more to do with mechanisms of how we learn, how we remember, how we problem solve, and pay attention rather than any actual knowledge. All right. So now it means when you're testing for cognitive abilities, there's even memory, there's reading, there's writing. All right. There's attention span. Okay. So all these are even calculation too. Calculation, ability to calculate something like an assignment or anything, is even retention, ability to hold attention of a person, the cognitive ability. Okay, so in view of this, all right, when you are talking about dementia, it means the person has lost some of these cognitive abilities, all right, that should come naturally. So now the main feature of dementia is memory loss, but there could be all these other impaired cognition, all right. But the hallmark of it is that despite the impairment of cognition, this patient is still conscious, all right. Consciousness is intact. You use Glasgow Coma Scale to determine whether a patient is conscious, but the patient may be conscious but not cognitive enough. All right. So you now use mini mental state examination to look out for cognition. All right. So apart from consciousness, you also want to test for cognition. So dementia is actually talking about cognition. Consciousness is intact. Okay. Now, the first differential whenever you see a patient with dementia, especially if it's an elderly patient, when you see an elderly patient, elderly is from the age of 65 and above. Okay, so when you see a patient with cognitive impairment, and memory loss is a hallmark. All right, memory loss is very important for Alzheimer's disease and is more in elderly and is progressive, gradual. It happens over years. All right. So maybe this patient starts forgetting his keys. It starts very little. It starts with benign, memory losses. He starts forgetting his car keys somewhere. He's just looking for it. Maybe start forgetting, okay, his child's birthday or one thing or the other. All right. Gradually, starts getting into bigger things. It gets to a point where the patient actually gets lost, wonders of because he doesn't know where he's going. He forgets the road to his house. He wonders of, all right, gets lost actually, and maybe he's found later and all that. So it's a spectrum of diseases, and eventually gets to the end stage, right? Where this patient doesn't even remember anybody, doesn't recognize faces, remembers no family members, has both long-term and short-term memory loss, okay, and all that. So now, Alzheimer's is the commonest cause of dementia in the UK, and of course, you want to write PLAB, which means you want to go to the United Kingdom. So they say it's the commonest cause of dementia in the United Kingdom, all right? Then it has a gradual onset, like cognitive impairment, okay? Then visual-spatial dysfunction, getting lost when taking a walk in the park or when driving, all right? So that's visual-spatial dysfunction, normally in old age. Now, when you want to diagnose it and you want to do a pathology of the brain, what you actually find is neurofibrillary tangles and senile plaques. Okay, so neurofibrillary tangles is the hallmark, pathological hallmark of this. I believe you guys can hear me. Sochi and Chara, I believe you can hear me. All right, I'm going to continue. So patient may be previously fit and well. There are behavioral changes as well. And you know, when you're talking about cognition, it's like the seat of cognition is in the frontal lobe. So anything that affects this will tend to give you this behavioral changes, all right? Aggressive behavior, emotional lability, depression, and patient may even have grand mal seizures as well. Grand mal seizures. What's grand mal seizure? There's petit mal, there's grand mal. Okay, what's grand mal seizure, guys? When you hear the word grand mal seizure, what comes to your mind? All right, so investigations, you want to rule out the following. Yeah, it's the grammar is generalized tonic-clonic seizure. Yeah, so you want to rule out the following reversible causes of dementia. Okay, you know, Alzheimer's is it has a progressive course, and when it starts, you can only manage symptomatically. Okay, you give drugs like donepezil and so on and so forth to try to improve the patient's outlook. All right, but eventually prognosis is the same thing. It will keep progressing the way it has been progressing. All right, only try to improve the well-being. All right, clinical state. So investigations, you want to do B12, so folate deficiency and iron, all right, to rule out all those causes, all right, iron deficiency and folate deficiency, vitamin B12 deficiency, all right. Then you want to do TSH to rule out hypothyroidism, HIV tests, because RVD can also be a factor in dementia, all right. Thiamine deficiency is also very important because of Wernicke's encephalopathy, all right. Then syphilis is also important. You do a syphilis serology and screening like BDRL come in handy here, all right? So you can also do a CT scan to rule out vascular dementia, subdural hematoma, or brain tumor, okay? I think I will even suggest that you actually brain MRI collections and any other thing, any other mass. If there's a tumor, if there's a space occupying lesion anywhere, if there's a hematoma anywhere, you know, because some of those things they are strong differentials. Okay, so it's when you kind of now zoom in on dementia when you don't actually see any other cause. Okay, so treatment is donepezil. And what is donepezil? How does it work? Dr. Noya, you are welcome. All right. So what is donepezil and how does it work? Noya, move stuff now. Move stuff. This is your area. Pharmacology. What's donepezil? Donepezil. Mechanism of action. What happens in Alzheimer's? I think you want to go into the pathogenesis. what happens in Alzheimer's? There's, yeah, of course, brain atrophy and all those things, creation of neurofibrillating tangles and all that. But what's actually happened there is loss of cholinergic fibers, right? So there'll be reduced ACH receptors, ACH itself, all right? So I want to give, um, yeah, welcome. Yeah, good evening. Okay, so vascular dementia is the second, say it's the second commonest cause of dementia in the UK. Now, once you hear anything is vascular, just know that that thing is likely going to be sudden onset, rapidly progressing. Okay. Now there's this so-called stepwise ladder of vascular dementia. All right, the patient is just stable. All of a sudden, bam, patient has a vascular event, and then from there, dementia develops. Okay, so it's kind of a dementia. What we call it in um, these terms is post-stroke dementia. All right, so it's a dementia that follows a vascular event. All right, so following a vascular event, patient now develops dementia. What we call post-stroke dementia. So also known as multi-infarct dementia. So it has a sudden onset, unlike Alzheimer's disease that has a progressive, insidious onset, progressive, progressive, all right, progressively getting worse, right? Unlike Alzheimer's that suddenly gets worse from a stable state, patient gets down. Okay, now that patient, and once that patient is already down, will not go up again, will remain on that state till another vascular event, patient will tip down again further. So it's like that. That's how vascular dementia occurs. So there's usually history of other associations. A patient with Alzheimer's, there may be no other history. The BP is normal, no type 2 DM, no alcohol, none of these common risk factors. All right. It's just that patient is elderly. But in vascular dementia, patient may or may not be elderly, but there is usually a history suggesting, because we mentioned that it's associated with infarct. So all the risk factors for what they call it, cardiovascular risk factors will be may, not all of them anyway at once, but many of them may be there. All right. So you want to know about the modifiable and non-modifiable cardiovascular risk factors. So non-modifiable ones like age, sex, all right, race, and of course, family history. They are non-modifiable. Then modifiable ones like hypertension, type 2 DM, alcohol, cigarette smoking, use of hypercholesterolemia, dyslipidemias and all those stuff. Okay, they are all there. They are all modifiable risk factors for this. So you now start talking about history of hypertension, type 2 DM, type 2 DM, history of ischemic heart disease, history of atherosclerosis, intermittent claudication. All right. So all this ischemic heart disease, atherosclerosis points to ischemia in other parts of the body, in vital organs like the heart and of course the blood vessels. Okay. There's stepwise correlation in cognition and memory. Investigation brain CT scan will show brain infarction. Yeah, brain CT scan will show brain infarction. But for me, I still prefer brain MRI, like I said, especially in the acute phase. Because when a patient comes with an acute phase stroke or something like this, you will not be able to see it on brain CT scan. It's a brain MRI that will pick an infarct within the first 24 to 48 hours, all right? But most times, brain CT scan will not pick an infarct, especially when it's a tiny one. And lacuna infarcts are known to be tiny. And it's lacuna infarcts are usually multiple areas of the brain, all right? So that will eventually present as dementia. Then the third type of dementia that is known is frontotemporal dementia. All right, frontotemporal, it means it affects both the frontal and the temporal lobes. Okay, and we know that the frontal lobe is associated with personality. So there's this thing about early intellectual impairment. Okay, so this person start having intellectual impairment very early, unlike in things like Alzheimer's, where Memory loss is the very early presentation, okay? But here, you start having intellectual dysfunction very early. So there's also visuospatial functions which are relatively preserved from the beginning, okay? And there's early personality change. Like I mentioned, the frontal lobe caters for personality and behavior, okay? And also intellect. So intelligence, behavior, personality are all catered for having emotional ability, easy crying, mood swings, depression, um, even aggressive behavior, personality changes. Someone could be someone that for doing so and so thing, behaving this way. All of a sudden, this person is behaving in another way that he was not known to be behaving before. And there's this simple proverb that you don't teach, um, okay, that an elderly person cannot learn how to use the left hand in the old age. All right. So you don't expect that elderly man to start changing when he's already old. So if there's a change, then think of a pathology. Okay. And in this case, think of the frontal temporal lobe. All right. Now, the another one we have is Lewy body dementia. It says the third commonest dementia in the UK. All right. One important thing about it is that it does not respond to use of dopaminergics. Now, hallmark of Lewy body dementia is fluctuating memory loss. Okay, fluctuating. So it kind of um, remitting and relapsing, remitting and relapsing. So memory loss, all of a sudden, patient gets back to normal again, then starts having memory loss again. So it's fluctuating, fluctuating. That's hallmark of Lewy body dementia, and it's associated with Parkinsonism. Of course, in Parkinsonism, you have symptoms of THR, right? Tremors, hyperkinesia, and then rigidity. Okay, hypokinesia, I mean bradykinesia or hypokinesia, and then rigidity. Then pathological findings, of course, Lewy body. That's why it's called Lewy body dementia. So, in the case of Alzheimer's, where you are finding what we call the neurofibrillating tangles in the brain, when you take a pathology, brain biopsy, and all that. But in this case of Lewy body, you'll be finding Lewy body dementia. Find Lewy bodies in the brain tissue. Then idiopathic Parkinson's disease responds very well to dopamine. Okay, Lewy body dementia doesn't respond. So even though Lewy body dementia is associated with Parkinsonism, all right, it doesn't respond very well to dopaminergic agents like levodopa, carbidopa, and all those stuff, bromocriptine. Okay, so that's how you differentiate it from if a person has normal Parkinson's disease and you give all those dopaminergics, patient is expected to improve in terms of clinical state. But with Lewy body dementia, there will not be an improvement, despite the fact that it coexists with Parkinsonism. Now, another disease we have come across is Huntington's disease. Those who have been regular with class will know that we have talked about Huntington's disease on multiple occasions, and it occurs in younger people. I know it's middle-aged, kind of 30, 35, 30, 55 years old, all right, middle-aged, usually females, a lot of females, and it has this strong family history. And it was okay. What's the pathogenesis again? Right, there's a strong family history. It is autosomal dominance. Okay, and things that are autosomal dominant. There's this reduced penetrance and variable expressivity. So with each generation, there's variation in the expressivity, right? But kind of it gets worse with each generation. Now, usually in young or middle-aged patients, and there's this strong history of chorioatetoid movements, slow written movements. Or I use the example of the movie House, there was a lady, can't remember her name, in the movie House, who House MD, who had this Huntington's disease. Okay, now she got it from her mother. They showed the image of her mother when her mother was having those slow written movements, like it's almost like the person is moving like a snake, twisting and turning in different directions. Like it's crazy, it's painful to watch. All right, and it has a progression, an inevitable progression. And it's said that some of them actually do commit suicide because it's like you are counting your dead days and you're seeing it coming because it has that constant prognosis that within 10 years, to irritability, right? They are restless all the time. Then from there, it gets into dementia with or without seizures, and eventually death within 10 years. So it's crazy. Now, there's a phenomenon known as pseudo dementia. Pseudo dementia is not a real dementia. It's actually due to depression, clinical depression. And in depression, like there's low mood, low affect, loss of energy, loss of interest in previously pleasurable activities, low sexual energy, everything is just low, excessive sleepiness. So by the time you're talking to this person, and this person is just quiet, looking at you, you may actually think that this person has dementia. You may think it's a cognitive impairment, not knowing that all this while this person just had depression. So it's known as a pseudo dementia because it's not real dementia, but as a result of um, the clinical features looking similar to dementia. Okay, so and it responds well to antidepressants because it is a pseudo dementia. Now, peaks dementia affects mainly cognition, all right, mainly cognitive impairment. Memory is usually normal. They score very well on the memory test, but cognition is affected. Unusual sexual advances. I'm talking about their sexual life. Okay, hyperorality may lead to stealing. That's funny. All right. Um, Wilson's disease, also known as hepatolenticular degeneration, all right, where there's excessive accumulation of copper as a result of the lack of the enzyme for ceruloplasmin, all right, lack of ceruloplasmin that is supposed to help in the transportation of copper. So there will now be an abnormal accumulation of copper in tissues like the lens of the eyes, the brain, okay, and of course the liver. So there will now be liver failure, may even lead to liver cirrhosis, liver failure, may lead to brain damage, all right, when copper is accumulating in the brain, lead to a lot of brain damage, and eventually what looks like dementia will occur. Okay, so there's accumulation of copper in different organs due to differentiation of protein, ceruloplasmin, which transports copper in the body. Copper accumulates in different organs of the body, including the brain, which leads to dementia. In the liver, it leads to liver disease. The joints leads to joint pain. In the eyes, it will cause what is known as the Keisha-Fleischer ring. Keisha-Fleischer ring, where the is it blue? What's that? What's the color of that ring? Keisha. Look at it. It's kind of brown. It's brown. That's the ring around the eyes. That's it. It's brownish. Look at it. It's very fine here. Look at this one. It's a Leicester ring. Very, very pronounced. Even the arrow is pointing on it. around the eyes. This pupil, will you say is dilated or is normal? It looks dilated. All right. So investigation, essentially you do serum copper. Okay. Now something else that looks like dementia is what is known as the mimic dementia, all right, and the need to rule them out before you have to see, all right, vitamin B12, vitamin B1, okay, then you have to rule out this copper Wilson's disease by testing for serum copper. You have to rule out hypothyroidism, all right? So you can see the importance of all those things now. Now, in the brain damage is due to deficiency of vitamin B1, also known as thiamine, in Wernicke-Korsakoff's syndrome. So now, there's Wernicke's encephalopathy and Korsakoff's confusion or Korsakoff's psychosis, all right? So now, in Wernicke's encephalopathy, usually due to thiamine deficiency, prolonged thiamine deficiency, and alcoholism is one of the things that leads to thiamine deficiency. So alcohol, chronic alcoholism can lead to Wernicke's encephalopathy. Now, the hallmark, all right, the triad of Wernicke's encephalopathy is what we know as confusion, ataxia, and ophthalmoplegia. When you say a patient that has confusion, ataxia, and ophthalmoplegia, patient may also have flapping tremor and headache. Okay. Now, Korsakoff's psychosis, you have confabulation, right? And that confabulation means that this patient is just making up stuff, trying to cover the gap because he has lost his short-term memory. So that's why you call it a psychosis. Patient is just talking irrationally. Why? Because patient is trying to fill up the gap in memory loss. So you may ask him, what's the time now? He will just, because he doesn't remember the time, he will start saying something else. All right? And that's due to short-term memory loss. So confabulation is making up stories due to short-term memory loss. So treatment essentially give them thiamine, and they will get better. Right? So it means to have a very good prognosis, because once you can find the cause, you can reverse it. There's this other mimic known as Creutzfeldt-Jakob disease, also known as prion disease or mad cow disease. Right? So prions are like proteins, infectious proteins, right? Which when they attack a person's cells, can actually incorporate themselves, okay, and start causing damage into the body's proteins, right? So prion is an altered protein which can be transmitted through blood transfusion or surgical instruments from one patient to another. So it leads to rapidly progressive dementia, leading to memory loss, personality changes, hallucination, very important. Okay? And it can transform other proteins to become abnormal. Therefore, it is infective. So prion is actually an altered protein. When it gets within the cell, okay? So it's common in hemophiliacs with history of previous blood transfusion, right? Multiple blood transfusion, in fact, because that's the risk for it. And accumulation of these prions in the brain causes dementia. There's no treatment available as of now for prion disease, Creutzfeldt-Jakob disease. Now, it's rapidly progressive. That's one thing to note. And since there is no treatment, it means prognosis will be very, very, very poor. Now, HIV associated dementia is one of the things we have on this list. That's why you do RVS. You know, there's one thing about HIV can affects the heart, affects the kidneys, causes high burn, affects the skin. There's no organ you mentioned, affects the lungs, even the eyes, everywhere. Okay, apart from the primary progression that it's having, it can also go to all these other organs and cause some damages, right? Which presents clinically. Now, a patient that you are suspecting has dementia, and you find the patient to be RBD positive, you should be thinking about HIV-associated encephalopathy and things like that. Okay, HIV-associated dementia. Right? So must be HIV factors for dementia presents with confusion, but this is a progressive confusion for weeks and months. Things about HIV, they are going to be progressive, slow, like in prion when the stuff is rapidly progressing, right? So there's normal age-related forgetfulness, all right? So that one is not a pathology, it's physiological. It's bound to happen. The person gets older, they start forgetting one or two things. Okay, patient has insight to the problem. That's where this differs from a dementia. All right, so patient with dementia has no insight, and the meaning of insight is when you know that you have a problem. All right. There's a saying that the first step towards solving a problem is accepting that you have a first part is, and really how you know that a patient is already doing well on medication is when they now start having insight, when they now start realizing, oh, I'm in the hospital, I had this and this and this is why I'm being treated, and I will accept my medication. That is the first step towards recovery. That tells you that the patient has a good prognosis and the patient is doing well. So as far as insight is still absent, you assume that the patient is not doing well, proven otherwise. So in age-related forgetfulness, patient has insight. In fact, they come and complain that I cannot remember. I tend to forget things a lot, forget things, It's just age-related and it's bound to happen. Some persons more than the others anyway, but it's bound to happen. All right. But so far the patient has an insight into what the issue is, you don't have to think it's dementia. So it is normal forgetfulness, which everybody develops with age. The patient is usually concerned and not happy about it. Okay. So patients with true dementia have no insight into the problem. They have no insight into the problem. Then there's this other thing about normal pressure hydrocephalus, and it's said to be a reversible cause of dementia seen in elderly patients. Okay, so it's a differential of dementia. Why? Because it is reversible. Among all these dementia, all these causes of dementia that we mentioned, which other one do you think is reversible? Maybe when you get Korsakoff's, when you give thiamine, um, many of these things are actually not reversible. So, like, no matter what you do for a vascular dementia, brain has been damaged, brain has been damaged. What you do for Alzheimer's disease, brain has been damaged, brain has been damaged. You know, hypothyroidism, well, possibly, not sure, not sure. So, normal pressure hydrocephalus is, you know, how do you know hydrocephalus on brain CT scan? You see ballooned out ventricles, ventricles, both the lateral ventricles, the third ventricles, the fourth ventricle, all of them are ballooned out. That shows you that there's an obstruction somewhere, or something is going on. Now, in the case of normal pressure hydrocephalus, there will be normal pressure, all right? But meanwhile, these things are ballooned out. Ventricles are ballooned out, right? So it is thought to be secondary to reduced CSF absorption at the arachnoid villi. So when the arachnoid villi, which is supposed to reabsorb CSF, okay, doesn't do that job anymore, or doesn't do the job very well. Maybe there are obstructions, things blocking it from actually taking up the fluid and absorbing it. If anything causes that, then there will be what is known as the normal pressure hydrocephalus. These changes may be secondary to head injury, subarachnoid hemorrhage, or meningitis. The classic triad of features is seen. There's urinary incontinence, there's dementia and bradyphrenia. Bradyphrenia means slow thinking, all right? Paucity of thought, slow, very slow, sluggish thoughts. That's bradyphrenia. Then gait abnormality may be similar to Parkinson's disease. Then hydrocephalus with an enlarged first ventricle. Like I mentioned, there must be enlargement of ventricles for you to say there is a hydrocephalus. Okay, so that's urinary incontinence is very important. When you see a patient that has dementia with urinary incontinence, okay, urinary incontinence, bradyphrenia, very slow thinking, then gait abnormalities, all right, and you do a brain CT scan, you see hydrocephalus, evidence of hydrocephalus by ballooned out ventricles, enlarged ventricles, you should think of normal pressure hydrocephalus. And why you need to think of it quickly is because when the neurosurgeons actually do something to relieve that pressure, you can have an improvement of clinical state. When they do something to remove that obstruction, the cause of the obstruction, you can have an improvement. So the management is ventriculoperitoneal shunting, all right? Ventriculoperitoneal shunting management. So on that note, I think we have done justice to dementia as a whole. Okay, try to cover all the sensitive areas of dementia. Do you guys have any questions before we pull out? Any questions for me? All right. In the absence of questions, let's call it a night for now. Thank you for coming around. And what we're trying to do now is to actually pick the questions one by one. Instead of just going straight to the questions, we want to